Hello, I'm Dr. John Kruse, and welcome to today's question and answer session on ADHD and mental health. So, as usual, I'm going to start with summarizing the three videos that were released last week, and then I'm going to be open for questions. Those questions can be on ADHD or other mental health topics, or specifically on those videos. It's up to you. And also mention that we've started a subreddit at Dr. John Kruse, which may be a more efficient or effective way to have post questions and have me and others try to answer those questions. So the three videos that were released this week, the new one was on the winter holidays and mental health. One was on depression and ADHD, and the third one was on accommodations for ADHD. So regarding the winter holidays in mental health, the thing to remember is and respect is that the holiday season is stressful, even though or maybe particularly because it's supposed to be a time of joy and cheer and everyone getting together. Expectations are high, and often experiences don't match well what's going on. Particularly for people with ADHD, this holidays can be difficult because there's an increased demand. So there's increased financial demands, spending on presents, spending on food, increased social demands, being out with different people, um, probably tasting foods or trying things you haven't had for a while, interacting with people you haven't interacted with all year round. So demands are higher, and at the same time, structure is lower. Part of the reason structure is lower in sport is that everyone else is busy too, so they can be of less help. And most regular routines around school and work are disrupted during the holidays. So that's a combination for stress and distress. Recommend sort of looking at three different levels: the biological, the social, and the psychological to help get you through the holidays. The biological, and there's other points here, but I'd stress getting enough sleep, minimizing alcohol intake, and getting enough light. So there's another talk on seasonal depression. And most of the rest of the psychosocial is managing expectations and saying no if the dose of social interactions is higher than you would want. So you can regulate that like you would regulate medications. Moving on to depression and ADHD. So there is a fairly strong association between depression and ADHD. Those individuals with ADHD are substantially more likely than the general population to wind up being depressed. One big reason for that is they share a common genetic set of influences. So both of these have a strong genetic influence, and most of that is a number of tiny, tiny effects from hundreds or thousands of different genes. And many of those that predispose for depression are also the same that predispose for ADHD. Second big reason for the frequency of depression among individuals with ADHD is that many of the executive function deficits, the not paying attention, the poor time management, the blurting things out or intruding or interrupting on others are a recipe for disasters or failures by social standards. They don't always have to be actual failures, but that means people with ADHD are likely to get much more negative feedback than the general population, and that seems to be a recipe for depression. Many of the treatments for ADHD do have some antidepressant effects. Some of the depression treatments, with the possible or likely exception of SSRIs, so SSRI antidepressants don't seem to have much impact on most studies that have been done of ADHD, but lots of other serotonin and norepinephrine reuptake inhibitors, monoamine oxidase inhibitors, bupropion, all those should have benefits for both conditions. And then the third video that was re-released, so this Max has re-recorded the sound on it, was about accommodations and ADHD. And this is addressed, I guess, primarily to the US audience here, but in most states and in federal laws, the workplace or school place is actually required to provide reasonable accommodations for your ADHD. Reasonable leaves a wide amount of opinion in the matter, but they should be interventions that are targeted to help you perform your job. And many people are reluctant to ask for or request accommodations, and I suggest framing them as efficiencies. If you frame it as an accommodation or think of it that way, that feels like I'm getting a special gift that other people aren't getting, and that can cause resentment by the people granting it, by coworkers, and feelings of guilt. If you frame it in terms of inefficiency, this is something that's being permitted or allowed, such as noise canceling headphones or longer time to do a certain thing or having notes to a certain meeting or lecture. Um, those allow you to more efficiently be productive and do the job that you're there to do, and that should make your boss happy if you're getting your job done. So those are the three videos, and I see there's some questions already. Also, I'll just again mention there is a subreddit we're trying to start. So hello, I guess good evening for you, Dennis. Dennis asks, does a stressful event like getting on an airplane affect GABA and cause panic, or does a panic attack happen because GABA is low in the first place? So that's a good question. I would frame it a little different. I would put it so the perspective I would offer is that the three neurotransmitters we talk a lot about, dopamine, serotonin, and norepinephrine, are all tiny numerically. Less than 1% of the cells, nerve cells in the brain, use those neurotransmitters. They all originate in small centers at the base of the brain and send ramifications spreading out all throughout the brain. On the other hand, when we talk about glutamate, which is the most abundant neurotransmitter in the brain, and probably close to half the cells in the brain use glutamate, or if we talk about GABA, which is an inhibitory neurotransmitter, and maybe a quarter to a third of the cells use that, we're talking about much more diffuse distribution of a certain neurochemical. So I mean, even if you're just measuring overall brain serotonin or dopamine or norepinephrine, that might not tell you much, but I would argue it tells you even less when we're talking about GABA or glutamate, or even just talking about levels, because we're talking about virtually every single complex connected system network in the brain is going to be using GABA and glutamate at multiple points in that network or system. So I don't know of much evidence to suggest that people who are more prone to panic or anxiety have low resting state GABA. So I would put particularly something like panic as much more, it is the release of a big burst of norepinephrine, both in the brain and in the periphery, and along with norepinephrine, there's epinephrine as well. Epinephrine's other name is adrenaline. So even though drugs that affect GABA can, like the benzodiazepines, like alcohol, can shut down anxiety, that doesn't mean anxiety problems are the result of a GABA deficit to begin with. So that's how I would try to answer that. So hello, Neospios. Just a happy holidays wish. Thanks, you too. So for all of you who are celebrating Christmas, Merry Christmas. And for all of you who aren't celebrating it, please don't be offended by that. Any other questions, either regarding the holidays or accommodations or depression and ADHD or anything that's been in the news about mental health? Because I see there's 5 or 6 of you watching. I don't have a lot prepared, and I know it's the holiday time, and probably it's may not be the most efficient use of your time spending it here. I can say a little bit more about some of the holiday tips, particularly social anxiety that I mentioned in the video. So one is remembering most anxiety can be thought of as an attention problem, and it's that your brain is focusing on some event that has not yet happened and actually is either quite unlikely or slightly unlikely or extremely unlikely to unfold the way you imagine it will be, but it makes sense to be concerned about certain events. It makes sense to be prepared for them. But beyond that, it does not make sense to be anxious or worrying about them. And usually, a simple question is, what can I be thinking about? What's going on now? What am I trying to accomplish or do right now? Rather than being anxious can be helpful. So you're welcome. So I'm getting a thank you from Antaresta Magome. Um, Thanks. Hope this is helpful for people. If there is, I'm assuming the sound is coming in at least okay today. I'm on Northern California right now, so the location, the setup is completely different than when I'm in Hawaii, and hopefully a better connection. I see a question. Neospose, I would like to know a bit more about depression and ADHD. How does an approach look like for someone who basically found out about both and more at the same time? Is there a priority hierarchy? So that's a good question. I'd say so often the situation comes in that arises that someone's had ADHD for decades and only the depression was being paid attention to or treated. So usually and often both situations were unresolved because the ADHD wasn't being treated. So one, I mean, if someone is in a life-threatening, overtly suicidal, or so depressed they're not getting out of bed or feeding themselves, I would say the depression takes priority. Other than that, it usually makes sense to address both of them at the same time. And again, many of the ADHD medications, including methylphenidate, including amphetamine, including bupropion, have well-documented evidence that they are helpful for not just lifting mood, but treating clinical depression. So one approach is if you're aware that both are there, is to choose medications to target them both. If you're trying to treat them in parallel with separate sets of medications, my thought there is that usually I recommend only changing one medication at a time and giving it at least a few days just so you can figure out what side effects, what positive effects seem to be ascribed to it. The other really important thing to remember regarding medication is that many of our medications, regardless of what labels we put on them, medications that boost dopamine or norepinephrine quickly should have a quick effect, quick meaning minutes to hours effects on ADHD. Those exact same medications, when they're having antidepressant effects, may take longer. Now, the stimulants, methylphenidate and Adderall, amphetamine, do work quickly for depression. But Wellbutrin, traditionally, the studies suggest, even though it may help energy right away, it may help motivation quickly, it may help focus and attention ADHD symptoms right away, tends to work over a 1, 2, 3 week period to reduce depression. So the same drug can have different time courses of action. And the other approach here is not to overly focus. It's not that medications are the only answer. I mean, they are. Dozens and dozens of studies suggest for ADHD, more likely to be effective and more powerfully effective. For depression, they have about as good a success rate as CBT or best talking therapies, and they happen to work substantially more quickly. But certainly CBT and other approaches, talking therapy wise, can help in both scenarios. So I'm not sure if there's other angles. If there's specific follow-up questions, I'm happy to try to address those with the depression and ADHD. So Contrasta Magome asks, what's my view on the gene of addiction? And I frame it more broadly as the genetics of addiction. So I think alcohol addiction is, or alcohol abuse or alcoholism is what's been studied most extensively. Certainly, there's other work on other substance problems. And it's pretty clear there's not just one gene that makes you prone to addiction, there's a host of different genes. Some of them have to do with how your body processes the substance. So if you um, different rates of processing it are some of them are protective against addiction and some of them increase your risk for that, but separate from just how your body metabolizes alcohol, there's genes associated with reward pathways, genes associated with salience of signal pathways, all of which can influence. So clearly none of them are determinative. I mean, one, you need exposure to the substance itself. So if you have a gene for alcohol addiction and you're never exposed to alcohol in your whole life, you're not going to have to worry about it. So all of our conditions, even those with strong genetic underpinnings, are always still an interaction between brains and their environment. Um, so I don't know if we're getting into the moral or psychological. I mean, does having genes for addiction mean that that person's less responsible for their actions or should be held less culpable for their actions? Um, that to me, if the gene forced you to do something, but again, the genes are always only increasing likelihoods rather than being determinative. So I don't know if that answers your question. So I'm glad to hear that the sound is working well. So 00 day 1337 has a quick question. They're on Wellbutrin for ADD and noticed cognitive performance is way worse on this med. Memory is non-existent. How is this reaction possible? So one is, even though even though the stimulants have the best track record and study after study of helping people with ADHD, they don't help everybody. So there are individual variations. We don't know all of those factors. Um, Sometimes people metabolize or break down a drug into different components that may give them unusual side effect or responses. So a couple things with ADHD and feeling the cognitive performance is worse, because again, that would be different than most people who are taking it for ADHD and different from most people who are taking it for depression, where in both scenarios, there's measurable improvement in some cognitive performances. So one could be, if it's too high a dose, it could be that you are too revved up, too jittery, too out of focus because of that. Um, I guess another possibility, and one I've talked about before, that part of what's affected by ADHD is your own attention and ability to monitor your own problems. So, and I keep using this example over and over again. Let's say at baseline, your biggest problem during the day is you go into the next room and you've completely forgot what you're going in there for. You're doing it 20 times a day, but because you're not paying attention, you know it's happening a lot. You think it's 10 times. You take a medication that, let's say, cuts it by 2/3. You go down from 20 to 7 times. Um, but because you're paying attention better, you're aware of every one of those 7 times. I'm jiggering the numbers wrong. Um, but we can create a scenario where you think you've gotten worse when you're actually gotten better because you are paying more attention to all of the incidences when it's happening. That doesn't sound like what's going on now, but it would be good to get someone else's external assessment of whether you're having more problems with memory than before. Um, Other than that, I don't have a good answer. I mean, I guess the third part of the answer is, if it's only been a few days, we know, even if you don't have ADHD, but particularly if you have ADHD, there's a lot of day-to-day variation between performance. Some of it is clearly sleep deprivation. So if Wellbutrin was leading to worse sleep, that could lead to worse performance the next day. So thank you, Dennis, who sent a tip. I appreciate that. Hello, Flenna. Max, happy holidays. So Flenna's noting that I spoke a little bit about doing research in the early 80s on bright light therapy early in my career for seasonal depression. Can I talk about the process of treatments going from research to market? I can talk a little. I mean, in the early days, in the early 80s, there were only a few labs. So Norm Rosenthal, National Institute of Mental Health, Thomas Ware there, Daniel Kripke at the University, UC San Diego. I think it was Robert Sachs in Oregon. There are only a handful of people doing research or exploration on seasonal affective disorder. And there were a number of small companies that were, some of them already made light products, like others sort of jumped in with interest in it. And then many of those small companies were doing their own research to figure out. I mean, in the early days, we didn't know even whether it was retinal exposure or skin exposure. So there's a fascinating study looking at having people swapped in burqas with just their eyes exposed to the bright light for winter depression versus sort of being in a tanning bed with goggles over the eyes, but extensive skin exposure. That demonstrated that it was that retinal exposure that led to this seasonal affective disorder resolving. I mean, there are other studies, some people, because in those days, this was before LEDs were widely available, the bright incandescent light bulbs that were used for these treatments were heated you up measurably. So some experiments, manipulated with a cool fluorescent bulb, do we get this equal brightness? And then others started looking at different aspects of the spectrum. So there was a lot of sort of close collaboration and interaction between people at these startup lighting companies. Many of these startup lighting companies, I think it was Apollo Light that was, I think, in Utah based, was later, they made the Go Light, bought out by Siemens Electronic, which was the biggest light bulb maker on the planet, I understand. In the early days when I recommended for my treatment, so by this time it was early 90s in San Francisco, the cheapest boxes I could get were from Northern Light Technologies, a Canadian company, because of the exchange rate with the dollar. But these portable boxes fit, they were an array, probably almost 2.5 by 3 feet long, of huge, long fluorescent bulbs. Again, this is pre-LED. So I'm not sure if I'm answering the question of the process of treatments going from research to market, other than, researchers came up with ideas, the companies came up with ideas, people did small studies, and with 1 or 2 replications, that was enough to jump into the market and start saying, hey, there's a study that shows. I mean, one of the innovations was a visor which used LEDs, but focused the light more specifically just towards the eye and the retina rather than whole face exposure. So it was 00 day 1337. Thanks for my attempted answer about the Wellbutrin. And they're noticing that they're feeling more energy, but it's worsening memory and attention every time. So I don't have anything more specific or insightful to throw out than what I just suggested there. And Max, if there's a more specific question on the moving from bright light therapy from treatment to research to market, let me know. I mean, the other thing specifically with the bright light, bright phototherapy units is that this is 80s and early 90s. There were a number of different companies making well-designed products that would deliver 10,000 lux of light, and lux is how many photons are crossing a square centimeter surface area if your device was placed the right distance away. One of the things to remember is if you have a really bright light, but you're too far away, you're not going to get that much. I mean, the sun is a really, really bright light, but it's really far away. But the intensity of light falls off with the square of the distance. So if you're twice as far away, you're only getting a quarter of the light. If you're 3 times as far away, you're only getting a ninth of the light. So there were sort of well-calibrated, well-designed products. And then once it was clear there was a market for those, um, other companies like the Sharper Image and others just knew, oh, phototherapy is a buzzword, and there were no copyright restrictions on using a word like that. So lots of gimmicky companies churned out their own products, many of which were not tested and weren't providing bright enough light and did not meet any qualifications, but particularly if they're not specifically marketing as a medical device, then the FDA can't intervene. So Max asks, any upcoming research you think shows promise in psychiatry for the future? That's a pretty open-ended question, but thanks. I think I mean, clearly there's some technologies that have come on the market in the last decade or two that are closer to being strongly helpful. So when transcranial magnetic stimulation was approved for treating depression, so those are magnetic coils. You don't need to be in an MRI machine, so there's more portability and accessibility. The success rate, and this was in people who had treatment-resistant depression, was pretty darn low. It was well under 30–40%. But I'd say increasingly we're learning more about what the parameters are for that, what the location of, where to direct the magnetic field to change presumably electrical currents within the brain. So I think TMS is on the verge of being much more productive and helpful for a broader range of people. There's technologies even older than that, direct cranial stimulation. So it's the direct cranial electrical stimulation are really low, like 2 or 3 amp. You can do it with a tiny little 9-volt battery. And that's, again, putting electrodes on the scalp and in the right area. And whether it's where the anode and where the cathode are, where the positive and negative terminals are, depends whether you're exciting or suppressing activity, theoretically anyway. I mean, that's been around for decades, but there's finally some good research that showing that there may well be real effects there. I think, I mean, the perennial hope is that biofeedback approaches, which have been used for decades, and most of this is a gross oversimplification, but certainly for ADHD, usually the size of the effect isn't any greater than you'd get from a non-specific, just this person's being treated in a study and the attention from that, they're going to show some improvement. But I think we're on the verge of identifying much more specifically what circuitry in the brains are involved in what sort of normal functions, and understanding what may be going on when in certain mental health conditions when those circuits aren't functioning properly, and hopefully ways to interact or work on those. I mean, and certainly for decades, most of our medications were focused on the dopamine, serotonin, norepinephrine, and now we are branching out more into glutamate and GABA and oxytocin and neuropeptide Y medications. I'd say the other advances are increasing awareness that probably metabolic effects. So there's, I'm forgetting his name, but the Yale psychiatrist who's written on brain energy. But I also think inflammatory processes in the brain are strongly implicated as at least a component of almost all of our mental health conditions, certainly ADHD, certainly depression, certainly a major role in dementia, and that being able to modulate things there probably should have some beneficial long-term effects on the process. Um, so that's fairly generalized without mentioning specific products, but that's, I'd say the thing to say there is that, and this is more generalizing from the drug field. I mean, there are many times a very promising drug, a drug looks very encouraging in small studies, even in somewhat larger studies, and then never makes it to market, either because it has more side effects or problems than it was aware of, or when looking at a broader group of individuals, it just didn't seem to do as well. And one of the biggest problems that plagues almost all psychiatry research is fairly huge placebo response rates that you don't see in much of the rest of medicine to that extent. That makes it much harder to differentiate, is your treatment working or not? There's one study that came out about 2 years ago, I think, and I talked about it, that suggests, I mean, we increasingly focus in terms of psychiatric assessment on symptom checklists. And if you have this and this and this, then that measures the severity of your condition. And this study suggested that we should probably be adding back in just an overall, are you feeling better? And that an overall question about how you're doing, how it feels like you're responding, actually substantially increase the sensitivity in terms of being able to detect that the drug is working. I mean, the person knew they're working, but being able to measure it and differentiate it, that was the most important addition as a question. It was a very general, broad-based question. So Neospios asks, is there a way to optimally emulate the strong effect of Adderall for countries that do not permit the usage of Adderall? Most countries in Europe. Is there a way to optimize Ritalin's help, so to speak? One is that one is that there certainly are some companies or some countries banning completely amphetamine-based products, and many others, so just making it much more difficult to obtain, and many doctors aren't willing to go through that paperwork. Or so it may be finding a doctor who you can build a strong alliance with and being able to get it. I mean, one major difference between Adderall and amphetamine and methylphenidate is both of them are strong reuptake inhibitors of dopamine and norepinephrine. But the amphetamine are also causing vesicular release. So you're not just getting the effects of the drug, of the neurotransmitters acting longer, you are getting a larger amount being released to act. So there's some evidence, there's debatable evidence how strong the vesicular release action of methylphenidate is, but without bringing that on board, which also probably brings on board some of the risks for abuse and psychosis. I don't know how to optimize Ritalin to make it more like a stimulant or a full stimulant. So Max is saying it sometimes seems like psychiatry is still a field with a lot of unknowns. How do you approach treating patients with conditions that we still don't fully understand? So there I would try to draw a distinction between understanding, knowing what helps, because they're different. So lots of people. So I'll pick on blood pressure, hypertension. Huge problem. Huge numbers of people have it. At a mechanistic level, we know what factors are important for maintaining blood level or blood pressure level. I mean, it's a simple plumbing problem at some level. We can measure it very objectively, how high your blood pressure is, and we have to be careful that we're doing it the same circadian time of day and the same physical position and the same limb or place in the body and a whole host of other factors. So blood pressure isn't just one thing or isn't just two things, a systolic and a diastolic number. But in terms of treatment, we have several different classes of antihypertensives that work in a number of different ways. And although there are some racial ethnic groups that may respond more likely to one agent or not respond to another, most of the treatment is largely kind of like picking an antidepressant. It's what side effects do you want to avoid, or if you've gotten a partial response from one, what logically might make sense to add on to it. But we don't, I would argue, we don't fundamentally understand why did this person develop hypertension and this person with similar background or similar eating habits not. Um, so I'd say in lots, but again, with hypertension, we can measure it precisely. It feels more real. It feels more scientific. Again, like with depression, we have a number of different classes of agents. We know their mechanisms of action we don't fully understand. So we can look at treatments and see, does this treatment work or not without knowing why it works or doesn't work. Um, in terms of, so at a clinical level, the answer is we already have tools that even if we don't understand what the parameters or even what the underlying brain mechanisms are as to why this person has this condition, we have some idea of what's not likely to work and some idea of what is likely to work. And we start from there, I guess. So another question from date 1337. He's been on low dose Ritalin. It helps ADHD, but it gives anxiety related palpitations. The cardiologist, he's been cleared by a cardiologist and says it's anxiety. How can one eliminate anxiety from Ritalin? I would work with a so one approach I don't recommend or support is using um, or using alone a body watch or monitoring system that's telling you, alerting you every time your heartbeat is slightly irrelevant or not irrelevant, irregular or speeded up or something like that. Usually I've seen those just add into someone's anxiety about their condition. I'd say basically, and I have a lot of this on a separate talk on panic attacks. I think it's using a CBT approach that's saying, training someone to understand anxiety does release norepinephrine, which does have a direct effect on the rhythm of the heart and on blood pressure. And that doesn't mean you're in a dangerous situation. And it's getting someone to cognitively understand that, to repeat that over and over to themselves, because part of what goes on in anxiety and panic isn't just heart rate going up, isn't just blood pressure changing, isn't just blood flow preferentially going to the big muscles. It's even within the brain, less blood flow is going to higher cognitive centers. It's harder to think or reason, but it's retraining the body's interoception, so awareness of internal processes to know, okay, this is going on. I can look at it, I can observe it, I can experience it, but I don't need to have to freak out about it. So it's breaking that feedback loop of, oh my God, my heart's going, and it's not a illogical, at least initially, fear to have if your heart's doing something that it's not used to doing, and you know the heart's pretty important to remaining alive. That makes sense. There'd be concern or alarm. Um, yeah, and 1337 is saying his their anxiety is more physical. If they take Xanax with the Ritalin, anxiety palpitations vanish, but because of potential for addiction, they can't use that on a daily basis. Could one use a beta blocker or an SSRI? Just your opinion. Um, Again, so I'm not making specific medical recommendations, but I'd say beta blocker should be likely to help in that situation. SSRI shouldn't be directly helping, and the SSRI is only helping through lowering of anxiety, which then makes it so. Again, I think a cognitive behavioral approach is far stronger in the long run than relying on medications to deal with that as a side effect. That's um, so. So that's where I would come down on that one. But individual results and situations may vary. So I'm not seeing any other questions coming in. Um, I'll make another shout out. So Max has set up a subreddit under Dr. John Kruse where questions can be posted. And again, they may be easier to search for answers or search for other people who had the same question in that format than sort of the fragmented format tied to different YouTube videos. I will be back next week, which will be New Year's Eve. I'll still probably be broadcasting from this room. So if you celebrate Christmas, have a Merry Christmas. If you don't, have a Merry week until we meet again, and stay healthy, stay happy. And I'm glad you were here today.